Hello, I'm Gail Stotler from Vein Access Technologies. I'm here today to present this webinar on behalf of medical professionals. They're your partner in continuing education credits in radiology. The subject today, titled Vein Access Injection of Contrast for Radiologic Technologist. It's the one component that basically nobody has addressed yet. So I start off with the elephant in the room. And that's because it is a subject that nobody wants to talk about. Everywhere in the world, it's basically ignored, and it's ignored by every discipline, not just radiology. And that elephant represents a lot of problems that are associated with the venipuncture part of the injection of contrast procedure. So I'm going to tell you the story. I'm going to tell you how some of those problems occur and then what we can do to prevent those. So the objectives for this course are to introduce the 21 STEM science-based vein access technique. 21 stands for 21st century. STEM, everyone knows, science, technology, engineering, and math. And I'm also going to identify the history of vein access, how this whole thing came to be, what was the beginning, the middle, and now where we're currently going. And then how to recognize venipuncture, vein access, as a surgical procedure, which nobody currently does that, but we will. And then to identify the science behind the skill of vein access. And that's the difference between what's currently done and what this future is. This is all science-based. And then I will teach you the new palpation technique. So there's two parts to venipuncture: locate a vein and access the vein with the needle. Today, I'm going to be teaching you how to locate veins, healthy veins. And what we're going to do is start off with a scientific fact that I hope is going to pique your curiosity, get your attention, and have you sitting there going, I need to know more. And again, the origin and evolution of vein access, and then some of the science. And that's going to be in the first half, this first hour. Then we'll do the second half. So I'm going to start by, again, reminding everybody that this is a problem in every discipline in the practice of medicine: nursing, radiology, and laboratory medicine. All the disciplines struggle with this particular skill. And the problem with this bad venipuncture, the major flaws in this skill, affect quality of care for the patient, the cost of the procedure and to the institution, and then the medical outcome, because it is adversely affected if this doesn't go like it's supposed to go. So this is the one, I call it a malpractice, bad practice, the one malpractice that the industry has not been able to fix until now. It's also been a problem that basically very few want to address. I shouldn't say that completely. Some of the tool industry has tried to make some tools to fix the problem, but it's not successfully done that. So we are now going to talk about the venipuncture procedure. This one skill is the first step in the injection of contrast. And if it does not go well, then the subsequent steps will be compromised in some way, shape, or form. So it is time to fix the problem. The first thing that I want to emphasize is that venipuncture is a surgical procedure. We're going to discover that since the beginning of time for vein access, it was considered a surgical procedure. It's just that nobody teaches it as such. But it should be treated as such, taught as such, and performed as such. And we're going to cover that in more detail as we go through this. So welcome to the next generation vein access. the 21st century vein access technique for locating, dilating, grading, and accessing veins for radiologic technologists for the injection of contrast. So the first problem then encountered is the venipuncture, and it's not a tool problem. The tools have all been scientifically designed by engineers, mathematicians, and they work if used correctly. If scientifically used, they work. So it's not a tool problem, it's a technique problem, and nobody's addressed that. So it's time to add science to this technique, and you'll see that it makes a big difference. We go from a self-taught, which every person in the world practically learns that way. It's pick up a needle and try and figure it out. Well, we're going to go to a science-based step-by-step method that does work. So vein access technologies did that. We did a step-by-step instruction because we did a step-by-step analysis. And my motto for this was where tools, technique, and science meet. I married all three, and it changes it dramatically. So first, how important is that injection of contrast procedure to the practice of medicine? When we look at a patient, it starts with the clinical impression by the provider, whether it's an MD, a DO, a PA, an NP, whoever the examiner is. And they come to a conclusion or an impression. And that's typically when they start ordering tests to support their position or in search of the answer. And one of the first tests done, of course, is laboratory, the blood test, with its venipuncture procedure. But the injection of contrast is the next most frequently used diagnostic tool. So it's pretty important. We all know that the steps to the injection of contrast or the contrast procedures start with step 1, the venipuncture. Step 2, the infusion or injection of contrast. Step 3, then we visualize the organ or the system being studied. And 4, the results. So venipuncture is the beginning. It's the foundation. We have to start there. What adverse effects does bad venipuncture have on the contrast procedure or venipuncture procedure? So here's a list. I call them the CCIFs, the complications, compromises, injuries, and failures. And to my knowledge, nobody has listed them this way in a concise manner in one group in one spot for any of the disciplines. And I'm not going to go through each one, but as you look through it, you go, yep, I've seen that and I've seen that. So we're going to talk about some of these as we go through it and how to improve it with this next generation venipuncture. Step 1 then is the logical place to start. So we need to know how to locate, dilate, grade, and access veins. And we're going to do the locate, dilate, and grade in this particular webinar per the 21 CVA technique. So the very first thing that I want to talk about, so I can capture your attention, hopefully, is Starling's equilibrium. Ernest Starling was a physiologist, and back in 1896. So all this that I'm going to be teaching you today is built on the science of previous scientists, Sir Henry Gray, Ernest Starling, etc. So these are not scientific facts that I've discovered or come up with. This is science that already exists. And this first one is Starling's equilibrium. And by the way, Starling did not come up with that math equation. A mathematician put that to it later. But he did come up with the physiology and the concept. And it's all about equilibrium, which means balance. So there's a balance between the pressure of the intravascular world and the pressure in the extravascular world. So there's an equilibrium between fluid that extravasates, moves in and out of vascular to extravascular and back. and it must be balanced or we get problems with it. So let's look at Starling's equilibrium and that physiology in some detail. So the science behind the skill with respect to this science, we're going to look at the tourniquet, the vein, and Starling's disequilibrium, as it were. And this is information that nobody has ever, to my knowledge, in any book that I can find, taught any of the allied health people, no matter what field or what domain you're in, of the what discipline in the practice of medicine. But there are side effects to the tourniquet. It's not just a matter of that thing hurts. There really are side effects to it. But first, let's check, pose some questions, see if you know the answers. And if you don't, then we're going to search for those as we go through this. But first, what's the pressure of the blood in the artery? And that's the brachial artery or antecubital region. 120/80. So 80 to 120 milligrams. What's the pressure of the blood in the antecubital veins? Nobody ever tells that story. But you're going to discover per physiology that it's 10 to 20 millimeters mercury pressure, a fraction of what it is in the artery. Keep that in mind. What's the pressure in millimeters mercury of the amount of pressure that the tourniquet is applying externally to those vessels? Well, that depends on who's applying the tourniquet, but it can be anywhere from probably minimum 80 millimeters mercury pressure up to 220, as tight as a pumped up blood pressure cuff. That's a lot of pressure on that 10 to 20 millimeter mercury vein. What effect does the tourniquet have on arterial flow? Cuts it off. And that was the whole point of the tourniquet, was to prevent bleeding to death. So it stops the flow of arterial blood. Well, here's another sidebar. We need arterial blood to make venous blood. Keep that in mind. What effect does that tourniquet have on Starling's equilibrium of the vein? We're going to go into great detail on this because it disturbs the balance of fluid in, fluid out. So what is Starling's equilibrium? Let's look at more detail. First, the tourniquet was designed then to prevent bleeding to death. And that's been the case since the beginning, since it was first invented. That was the mission. So the tourniquet never was designed to dilate a vein. That's a side effect. Now, origins and evolution. So the tourniquet, if you're going to call it a dilatation, you have to call it an artificial dilatation, because what that tourniquet really does is forces an over distension of that vein. Forced over distension. That even sounds mean. It is. And when you force that over distension, you disturb the anatomy of that vein wall, the structure. And consequently, you disturb the physiology of that venous system, the function. Now, okay, I can see my diagram didn't get changed, but here's what we need to know about this one, because this is incorrect. Right now, look at normal vein wall thickness. Your vein wall has a certain amount of wall thickness to it, okay? But as that vein distends, just like a water balloon, the wall doesn't get thicker, the wall gets thinner. And at a certain point, that venous system begins to leak. And that leakage in the science world is called an extravasate or a transudate. In the nursing world and the radiology world, that leakage is called an infiltrate. We've all heard that, we've all seen that. But that's where it starts, the split second the tourniquet's put on. In the lab world, when fluid leaks out of the system, it affects the laboratory results, falsely elevating certain components. That's not a good thing. That's called hemoconcentration, the blood concentrates. So infiltration and hemoconcentration are just two of the many side effects to the use of the tourniquet in venipuncture. We can't have that. So looking at what everybody recognizes, this little diagram, we have a vein, which is certain wall thickness. And again, vein wall thickness varies throughout the body. We're going to talk about that a little bit later. Then it goes down and becomes a venule, a little vein. And then we get to the membrane part, the capillary membrane part, the venous part of the capillary membrane. So vein wall is thickest, venule is thinner yet, and then the membrane is tissue thin. So we get a little bit of leakage at the vein, we get a little more leakage at the venule, but we get profuse leakage at the capillary membrane level, the venous capillary membrane. That is Starling's equilibrium. That is Starling's physiology, 1896. So here are some pictures of infiltration. Now, obviously, infiltration can occur from lymphadenectomy, usually from mastectomy due to breast cancer, but anything that affects extravasation of fluid and the poor return or uptake of that fluid can result in swelling. And the diagram on the left can reflect even infiltration from an IV. And you've all seen that, the puffy IV site. Okay, so all of those are consequences of Starling's disequilibrium, regardless of what the cause is. When the venous system pressure exceeds normal, you get leakage. So the split second that tight tourniquet is applied, leakage begins. That's the side effect. Now, do you recall when we talked just now about that lymphadenectomy patient? They said to you, no lymph nodes, no IVs, no BPs, and no blood draws. Okay, it was because of the swelling. But it was because the tools caused the swelling. The BP cuff and the tourniquet apply external pressure to that venous system, causing it to leak. Now, if you don't have lymph nodes, you can't get rid of the leakage, but we're talking about injection of contrast. If you get leakage, it's not just fluid from the venous system that's leaking out into your subcutaneous tissue, causing a swelling. It is contrast leaking out with that fluid into your subcutaneous tissue, into the patient's subcutaneous tissue. We don't want that. So who knew? Who knew all of this? Well, actually, a lot of people did. PhDs in the medical profession, some MDs, engineers, and they all wrote articles. But they never described it with respect to what the tourniquet does to it. They all say anything that disturbs the equilibrium is a problem. Well, the tourniquet disturbs the equilibrium. So again, you get hemoconcentration, you get infiltration, you get extravasation. But none of these researchers and none of these MDs provided any solutions to the problem. Because if you stop to think about it, they've all focused on where's the vein. So they've built new tools for that, even though there's an issue with those. But nobody's addressed this leakage problem. We will. So, tourniquet side effects. We can't use that tourniquet then to dilate a vein, to locate the vein. What are we going to do? So current methods, what you're currently doing out there is number one, primary, you're looking for a vein. There's a problem with that. You can't always see a vein. The veins can be deeper in the tissue, so they're not visible. the skin can be too dark, so the blue is not visible. And even if you could see a vein, what you don't know is, you've heard the expression, you can't judge a book by its cover. Well, you can't judge a vein by its either. So there is more to that story than just seeing a vein. The next method, they want to smack, slap, flick, or tap, thinking that that's going to enlarge the vein. They don't know it. We're going to talk about it shortly, but that actually causes vasoconstriction, not dilatation. They want to use a vascular diagram as a map overlay. Well, the anatomist will tell you only 50% of the humans have anatomy that looks like that. The other 50%, they're just not in that exact spot. So it's never meant to be a map overlay. And the other thing too is there are more than those labeled veins there. There are veins there that don't have names. Now in 1858, when Sir Henry Gray did the dissection, did the drawing and labeled, he didn't give all the veins a name. And that's because he didn't know back then that people were going to be searching for veins to put needles in them. And back then, arteries were important, not veins. So all the arteries got names, but all the veins didn't. And so when you stop to think about it, everybody wants to go for those 4 veins in the antecubital region that have a name. But there are more veins in that region than that. They want to use the tourniquet to dilate a vein to make it easier to locate the vein. We just had that conversation. We're not doing that. They also try to use a vein finder tool or the ultrasound machine. Wonderful inventions, truly. I mean, ultrasound's been around for forever for other, flow study purposes. But the point is, for venipuncture, especially the vein finder tool, will only penetrate so far beneath the surface of the skin. And approximately 50% of the veins you and I are going to have to access for healthy veins aren't visible with that vein finder tool. Even when you locate it with our technique, they're still not going to be visible with that tool. And even if you use the ultrasound, you really don't still know about vein wall thickness, characteristics that we're going to need to know before we stick the vein to determine if it's a vein that's going to tolerate the stick, what size is it, etc. And then the last, they want to palpate with a glove on. Well, if there's a barrier between you and the structure you're feeling, there's a barrier. And there are those who want to tear off the tip. Well, the guy who made the glove is probably hysterical at this point, because now you no longer have a barrier between you and that potential risk of exposure to patient bodily fluids. So this glove thing, we're going to fix that problem as well. So we need a new method for locating veins. And we're going to use the 21st century vein access method. At least initially, you're going to try it. There's nothing to lose. Okay, so we need anatomy, physiology, chemistry, physics, math, and some engineering for this story. And we're going to add some of those to this as we go through. So first, I want to tell you how we got here. There are 3 historical periods or eras to this venipuncture vein access procedure. In fact, it's vein access. The first period was bloodletting from the 5th to the 19th century. The next then became the phlebotomy era, and all the venipunctures are built on that phlebotomy foundation. And then we have the next generation, the 21 CVA. So let's look at this in a little bit of detail. Bloodletting or phlebotomy, and I didn't give that word, obviously, 5th century, that wasn't my invention. But the word phlebotomy, phleb means vein or vessel, otomy means surgery. And that's what I'm telling you. From its beginning, it was considered a surgical procedure, even though the first person to do it was not a surgeon. The first person to do phlebotomy, bloodletting, was the barber, took his razor and cut. They didn't know what was wrong with people. They just figured it was bad blood. So bleed them. Maybe they'll get better. That wasn't the solution to the problem, but they didn't know it. But at some point in evolution, the surgeon got in on the picture and developed the scalpel. So the razor got replaced by the scalpel. But the problem was people were still bleeding to death, so they continued to use that tourniquet to prevent bleeding to death. And that was the proper place for the tourniquet and the proper use for the tourniquet. Now, in 1853, Woods and Provaz invented the hypodermic needle, the basic needle that we use today. Needles were invented before then, but this is the one that's come to be used now. But the point is, in 1853, when the needle was invented, they finally put the razor and the scalpel away. Thank you. But at that point in time, when it went to a needle and the risk of bleeding to death was no longer a risk, that tourniquet should have been put away, but it wasn't, because it got harder to find that vein that you're going to stick with that microscopic needle. And again, somebody went, you know, if you put a tourniquet on, it'll enlarge that thing and it might make it easier to find it. But we all know that that doesn't work real well. Okay, so the foundation then for all vein access procedures, all venipuncture procedures, were built on the bloodletting procedure. So no wonder there are so many problems. All venipuncture in the second era is built upon the bloodletting foundation. And this second era then became also a trial and error, just like bloodletting was. A little more sophisticated, but still trial and error, empirical and anecdotal, evidence-based. Well, this works for Jack. Well, this works for Jane. Well, this group is doing this. So it still wasn't science-based, it's evidence-based. And unfortunately, I call it the stick and hope you hit something and keep sticking until you do meth. So that doesn't work real well. And we really don't want that for our patients. So along came me, and I realized early on that there's a better way to do this. And when you apply science, it not only explains all of the problems, but it'll give you the solution to those problems. So this 21 CVA technique has a few components to it, and we're only talking about one today, but it's the new palpation technique for locating, dilating, and grading veins. There is going to be a tool that replaces the tourniquet. We want something that supports the vein, not that distorts the vein. And then there's going to be new needle angle of entry information and pressure grip assessment, but that's later. Today, we're going to focus on the palpation technique. So again, why do we need to change anything? Why not keep going like we are? Well, if venipuncture goes well, then you've eliminated one of the possible interference factors in the infusion of contrast procedure, because we know there are some other problems that can be had. But if vein access doesn't go well, that first step, all kinds of side effects occur. And you've already set your procedure up for failure. And the medical outcome isn't what it should be. It can't be relied upon as being what it purports to be. So again, I want to remind you, the problems with the first two eras, the compromises, complications, injuries, and failures are many. And there are articles on every one of those. We're going to fix that. So to do that, number one, we have to scientifically understand the tools, how they were scientifically designed, how they were meant to be used, and then instruct people on how to correctly use tools. Because right now, you all know, one person holds the needle one way, one person holds it another, one person applies the tourniquet tight, one person applies it loose. It's kind of a free-for-all. I call it art class. But we're not interested in somebody's impression. We want the science base. And so we need to develop scientific technique then for performing this procedure to avoid all of the CCIFs. All right, so we can't use a tight tourniquet. What are we going to do? I wanted to refresh your memory and recall what the two previous eras are doing, not this new generation. Old information. They look, they smack, slap, flick, or tap. They use a diagram, they use the tourniquet, they want to use a pain finder or ultrasound tool, and they want to do strange things with the glove. Those methods are not working well. Ask any patient.